Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. We are back with Dr. Bilezikian, who is Professor of Medicine and Pharmacology in Columbia University. And last time we had discussion with him about the Armenian Heritage Cruise and the coming events in Armenia for osteoporosis. And today we're going to discuss about this silent disease that affects millions of people in the world as well as in the United States. It's osteoporosis. Dr. Bilezikian, let's define osteoporosis, simple way to our audience.
Yeah. Well, osteoporosis first is one of the most important global diseases that we have to deal with. And the question about what is osteoporosis, we could be very simple about the definition. It is the fracture. So the big problem with this disease is that it's a silent disease, but when it happens, that is, the fracture is really can be very devastating.
And not it's silent anymore. Now it's a known osteoporosis.
Right. It goes from, that's correct, it goes from being a silent disease to being a devastating disease. In fact, that hip fracture occurring in a woman who, again, happens, as it were, without warning, can be associated not with just the fracture, but with death. There is a 20% mortality rate in women who have sustained an osteoporotic hip fracture within the first year of the event.
Actually, for men, I think it's even a little more of the risk factor than dying from first year after a hip fracture.
Yes.
With osteoporosis.
Yes.
So men gets affected too, obviously, but not as much as women.
That's correct. And for that point, one reason why men have even a higher mortality rate is they tend to be older when they develop their osteoporosis and their hip fracture. But for both sexes, we are dealing with a big problem. And again, getting back to the definition, it's a condition of weakened bones. And now that we have a technology to identify individuals who have weak bones before they get the fracture, the good news is that we can diagnose the disease before it leads to the fracture, and we can do something about it.
Then let's talk about the phrase of osteopenia. So what is osteopenia and then osteoporosis?
Right. Yeah. Well, that's a very good question. So let's start with osteoporosis. How do we define osteoporosis? I mentioned the fracture. That's the end result of the disease. There's an analogy with the heart attack. Someone who has a heart attack has coronary artery disease.
Right.
Right? Well, someone who has had a fracture, short of an automobile accident type fracture, has osteoporosis. But we want to diagnose this disease before the fracture occurs. And the way we diagnose this disease is by having that test called the bone density test. In medicine parlance, it's called the DEXA test. I think many of you have probably had a DEXA test. And in fact, the Bone Mass Measurement Act of 1998 entitles all women over the age of 65 to have this DEXA test. Now, how do we diagnose osteoporosis? By getting the DEXA test, and by a certain number, we call it a T-score number, which reflects how much bone has been lost compared to a younger, healthy woman. And that magic number is a minus number, minus 2.5. So any score below minus 2.5, when the back is measured or the hip is measured, is osteoporosis. Now, what is osteopenia? Osteopenia obviously is not osteoporosis. It is a never-never land, if you will. It's a T-score between -1, that's important because any score better than -1 is normal. So somebody with osteopenia does not have a normal bone density, but they don't have a score less than -2.5.
That's in between.
It's an in-between categorization. It doesn't mean that the woman has osteoporosis. Right. It doesn't mean that the woman is going to become osteoporotic, but it's a warning. Right. And it gives us pause to try to determine why that woman has osteopenia and try to take measures so that osteoporosis doesn't develop.
So now we know osteoporosis is really the end and fracture coming at that time. There are certain risk factors that we cannot modify, let's talk about that first, that people should know what are risk factors that they cannot modify, and then we'll talk about modifiable risk factors.
Absolutely. So the risk factors for osteoporosis, the unmodifiable risk factors, a person's sex.
Sex, right. Women are more...
Women are more vulnerable, so you cannot do, well, we don't say,
right.
You're a woman, you're at risk.
More chance.
That's
right.
it, right. So that's something we can't do anything about. Age.
Age we cannot
do anything about age. Family background.
History. Mm-hmm.
You cannot do anything about your genes.
Right.
At least not yet.
Right.
So these are what we call unmodifiable risk factors, and we live with those.
Bone structure, small bone structure versus other bone, and then some nationalities have more, probably.
Yeah. So the ethnic differences and big bone, small bone, that's all probably genetic.
Yes.
So we're probably all talking about a genetic basis. Some of us are lucky, and some of us maybe not. So these are all the unmodifiable risk factors.
And there are modified risk factors. We can do something about it, at least help to reverse that.
That's right. So the modifiable risk factors we can do something about. For example, smoking. There's no reason why anybody should smoke cigarettes, because they're all, whatever system you're talking about, smoking is bad for it, and for bones, smoking is terrible. Another modifiable risk factor is alcohol. Now, I'm not here to say alcohol is bad. In fact, alcohol intake up to a certain point can be beneficial for skeletal health.
With the alcohol, now they are saying more than one drink a day for women increases the risk of certain cancers. Mm-hmm. So we would say not more than one drink a day, and for men, it could be 2 drinks.
Sure.
And let's go from there. And we include this in the lifestyle prevention, and that is exercise comes there too. Right? Activity.
Yes. And exercise is, again, something we always recommend. For skeletal health, exercise is beneficial. My patients ask me, well, doctor, what kind of exercise?
Exactly. Yes.
And, I have a very simple answer. I don't care. Yes, there are some exercises that are better than others. Like walking is an outstanding exercise. Working out in the gym
right.
with treadmill-type exercises, good. But if a patient of mine is swimming,
right.
for example,
right.
I don't tell that woman, don't swim. Swimming is a cardiovascular exercise,
right.
and that will help.
There are other risk factors like medications, let's say.
That is correct. Certain medications are a risk factor. The most important one is a medication called prednisone. Prednisone is a very important medication. Patients
any form of cortisone, we should say.
Cortisone, correct. Any form of prednisone is the prototypical one. But yes, cortisone or the equivalent. And there are diseases for which cortisone is very important, like asthma, for example. People who are taking a certain amount of cortisone for a certain amount of time, like over 3 months, are at risk for bone loss. Cortisone can be very, very bad for bones. Now, I'm not saying you shouldn't use cortisone. It depends on the problem. But we try to use as little as cortisone as possible for as short a time as possible.
But some people, unfortunately, have severe rheumatoid arthritis. They're given. So we'll talk about, when we talk about the treatment, we'll talk about how we can do probably additional things for those people.
That's correct.
So how about some other diseases? Let's say some certain hyperparathyroidism, let's say. It can cause osteoporosis.
Sure. Well, there's a very long list of the so-called secondary causes of osteoporosis, and that is things that lead to osteoporosis. We talked about medication for sure, but there are diseases, and one of the most important diseases that can lead to osteoporosis is rheumatoid arthritis. Now, rheumatoid arthritis is prednisone and cortisone is used for rheumatoid arthritis, but it isn't that alone. It's the disease itself. Chronic obstructive lung disease is another disease for which patients can be at risk for osteoporosis.
The deficiency of the calcium intake and vitamin D. Let's talk about that.
Yeah.
Some people are deficient really, and they're not having enough nutrition for it.
That's correct. So we always start with nutrition. When patients say to me, doctor, what medicine will help me? I say, no, we're not talking about medicine. Let's talk about your nutrition. Let's make sure you're getting enough calcium. Let's make sure you're getting enough vitamin D. Let's make sure you're getting enough protein in your diet, because these are building blocks.
Right. Let's quickly talk about the treatment of osteoporosis. So what kind of treatment we have available for our patients?
Well, we have had a 20-year now I guess it's a 22-year experience with a number of very, very effective drugs for the treatment of osteoporosis. One class of medications is the bisphosphonates, but we have other medications as well. I'd like to just note that these medications are extremely effective. Some of you may have heard about some rare side effects of these medications. We are concerned about side effects, of course, but we're also concerned about a broken hip.
How many years usually you recommend? Just quickly, I want to just get that to the patient.
Well, we usually typically recommend a period of 3 to 5 years of one of these medications, and then we will reevaluate. And some patients need further treatment, some patients don't. Some patients need what we call a drug holiday. Basically, we stop them.
How do you do follow-up with the medication? Patient is on medication. What do you do for follow-up?
Well, the follow-up I like to do is that DEXA test. I think the DEXA test is extremely useful.
Long later?
Well, the Medicare regulations say every 23 months. But let me just make a comment that I think in certain situations we do it more frequently. Granted, it would be against the Medicare guidelines, but in patients who we're really concerned about, they're losing bone density rapidly, I won't wait 23 months. I'll do it more quickly.
Right. So we have oral medication, pill form, and we have injectables, and that depends for the patients. Obviously, we select, depends who needs what.
That's correct.
Yes.
Yeah, we have oral medications. We have medications that are given as a simple injection under the skin. And we have medications where we give it by intravenous infusion.
Okay. Dr. Bilezikian, thank you very much for enlightening us about osteoporosis. Hopefully we'll do another program with you in the future AAHPO TV programs.
Great. Thank you very much.
Now it's time for this week's article, and it is fried potato consumption and mortality. White potato has been a staple food in many traditional diets of Western world. In recent years, the processed potato intake, like French fries and potato chips, has dramatically increased. Average American consumes 115 pounds of potato a year, of which approximately 2/3 of them are French fries and potato chips and other processed potato products. Even though potato provides some vitamins and minerals like potassium, magnesium, vitamin C, and vitamin B6, they are rich in starch and high in glycemic index, which have been associated with risk of developing obesity, diabetes, and cardiovascular disease. Therefore, potatoes represents a contradictory food because they contain both micro and macronutrients with the possibility of beneficial and harmful effects on health. Recently, a study was done both in Italy and United Kingdom about a consumption of potato and the mortality. Researchers investigated whether potato consumption, including fried or unfried potato, is associated with increased premature mortality risk. More than 4,000 people aged 45 to 79 years old, men and women, participated with 8 years follow-up. Participants with consumption of baked or mashed potato intake did not show any increased risk of overall mortality. However, participants who consumed fried potato and potato chips 2 to 3 servings a week or more were at increased risk of mortality. The conclusion of this study was only French fries and potato chips, which are fried, increase the mortality, not unfried potatoes. If you would like to have potato with your meal for its beneficial micronutrient content, have it baked or mashed, and stay away from any kind of fried potatoes. Good health is precious and priceless. Keep informed. Visit AAHPO's website, aahpo.org, for up-to-date medical information. I'm Dr. Orhan Corrado Prag. Until next program, so long.